go ahead and start. So welcome everyone to our MPRINT webinar today. Pleased to introduce Prince Kannankeril, who is one of the PIs of Vice MPRINT at Vanderbilt University Medical Center. And he's going to talk today on precision medicine in pediatric cardiology. Prince?
Yes, thanks so much. And it's great to be here. I usually give this talk to a pediatric cardiology slanted audience, and so I have to explain a little bit about precision medicine. So this will be different. I'm guessing most of the people that are tuning in are aware of what precision medicine is, so I'll do a little explaining about pediatric cardiology. I've got no significant relationships to disclose, although I probably will discuss some things that are considered off-label. So it's probably important to remind folks that pediatric cardiology is primarily concerned with congenital heart disease. And it was not until relatively recently that children with congenital heart disease survived to adulthood. So this is data from the United Kingdom, but the data in the US is very similar. And so this is showing the percentage of deaths attributable to congenital heart disease. And you can see in the blue columns, most of these deaths were occurring prior to 1 year of age. And that didn't really change until sort of the late 70s, early 80s, thanks to some innovations that are listed on the bottom of the slide. And then as you can see, the infant deaths are dropping and the deaths are now occurring beyond 15 years of age. And of course, it's not like 15-year-olds are dropping dead. We can look at data from Norway. This is looking at the actual number of deaths due to congenital heart defects over 40 years from 1971 to 2011. And again, you can see the number of deaths under 15 years of age are dropping pretty dramatically during that time frame, whereas the deaths above 15 are staying pretty stable. So many children with congenital heart disease we now expect to live well into adulthood. And in fact, a common statistic that's been thrown out for a few years now is that there are more adults with congenital heart disease than children living in the United States. So that's the good news. We've made some progress. But the bad news is congenital heart disease is still a leading cause of infant death in the United States. This data is from the CDC in 2017, showing the top 10 leading causes of infant deaths. And you can see at the top there is congenital malformations. And among congenital malformations, congenital heart disease is the most common. It's about 1 in 100 live births. So that means every year in the United States, there are 40,000 children born with congenital heart disease. Half of those children will require surgical intervention at some point in their life, a quarter of them in the first year of life. So that means there are 10,000 infant heart surgeries being done every year in the United States. And among congenital malformations, the largest proportion of deaths is due to congenital heart disease. So it is still a leading killer of infants here in the United States. It's also associated with the highest hospital charges, length of stay, and mortality among congenital defects. So this is pretty old data now, but almost 10 years ago in the United States, we spent $6 billion just in hospital costs for congenital heart disease. The inpatient surgical cost was $2.2 billion. Looking at this another way, congenital heart disease is the indication for hospitalization less than 4% of the time for United States individuals aged 0 to 20 years of age, but they represent more than 15% of the cost of those hospitalizations. So congenital heart disease is a big problem, both from a morbidity standpoint and also for a cost issue. So when we talk about precision medicine, we do have to recognize that in pediatrics, there are some significant barriers. So our populations are smaller, right? If you want to study diabetes, there are many more adults with diabetes than there are children. And they also have fewer outcomes, partly because those outcomes take a while to develop. So that's obviously good for the patients, but that means it's much harder to study. You also all recognize that sample collection is harder, right? You can't draw 5 tubes of blood from a neonate, just to collect DNA and biomarkers and drug levels. We also have limited phenotyping in children. So take the average adult who's admitted to the hospital, they get a lot more tests done than the average child that's admitted to the hospital. And then lastly, we have fewer drug exposures in pediatrics. And so I've been making the case that one of the greatest opportunities we have for precision medicine in pediatrics is the period right after congenital heart disease surgery. So As we've already gone over, morbidity is high, so we have a lot of outcomes that we can study. Many of these can be ascertained in a fairly short time frame. Some of the barriers to sampling are minimized by the invasive procedure, although we've got to get somewhat creative, and we'll get into some of those methods in a bit. We also do very dense phenotyping in the postoperative period. So if you've spent any time in the pediatric cardiac ICU, you know that we're monitoring these kids invasively. We're drawing labs very frequently. We get an echocardiogram at the drop of a hat. If they're not doing well, we do a heart cath. And so if you look at the electronic health record of somebody with congenital heart disease, you'll find it's very dense right after they have surgery. And then lastly, we have multiple drug exposures. So almost all of our patients are on multiple drugs. These include sedatives, analgesics, opioids, antibiotics, antiarrhythmic drugs, and so on. So we have a lot of opportunity for precision therapeutics in this population. This is a great example of precision medicine in pediatric cardiology. So this is a slide from one paper showing tacrolimus level normalized to weight-based daily dose and stratified by CYP3A5 genotype. So tacrolimus is a drug that's used to prevent and treat solid organ transplant rejection. And as many of you know, one of the ways it's metabolized is via CYP3A5. And most individuals of European descent are actually homozygous for the STAR3 allele, meaning they don't make a functional CYP3A5 enzyme. And so they have relatively higher levels for the same given dose as individuals that are heterozygous for the STAR1 allele. Now, transplant doctors typically follow drug levels, so they eventually get all their patients to the right spot. But if they expect their patients to behave like the majority of patients do, they're probably going to underdose these individuals. And these individuals are, in fact, at increased risk for early rejection. And so there is a CPIC recommendation that your initial tacrolimus dose is based on your CYP3A5 genotype. If you're a poor metabolizer, like most individuals of European descent, you start with the standard dose. If you're an intermediate or extensive metabolizer, you start at a higher dose. Now, this is all well and good, but obviously you've got to have that genotype information in hand when you're ready to actually prescribe that drug. You can't wait, for a genotype to come back if you've got to treat that patient. And so at our institution, we have this program called the PREDICT program. And so PREDICT is essentially, it's a blood test that anybody can order and send. And when that is done, the patient is genotyped for multiple polymorphisms in multiple genes that have known drug gene interactions. And importantly, this is operationalized in such a way that that information is in the EHR, but nobody has to really know where it is to find it. Basically, if anybody goes to order a drug that's on this list of actionable drug gene interactions and that patient has had the PREDICT test done, then they'll get a little pop-up that says, based on this patient's genotype, it's recommended that you start with, this dose with links to the evidence that supports that recommendation. So this is very useful. Unfortunately, in pediatric cardiology, that tacrolimus example is really the only one for which there's recommended evidence. And if you talk to our transplant doctors, they actually say they don't really rely on tacrolimus very much in the early transplant period. So they actually don't really care if it takes them a while to get up to therapeutic levels. They have other ways that they treat rejection nowadays. So we don't really have an evidence base for which to use these drug gene interactions. And so we've decided it's up to us to generate that evidence base. And so for a long time now, since 2007, actually, we started enrolling patients that come to surgery here in an observational cohort study. And so this is a consented biobank. So, we do approach patients for consent and they can refuse, but most of them are invested in this and they're happy to participate. And it's really just an observational study. We don't treat them any differently. We simply have permission to get a DNA sample and to look at their outcomes. And so over time, this cohort is built up to over 3,000 unique individuals who have undergone more than 4,000 congenital heart surgery operations. And we've been able to start to generate that evidence base. And so we've looked at a number of outcomes, but I'm an arrhythmia doctor. So we started our focus on arrhythmias. And so we'll go over some of these. So the first outcome that we looked at is an arrhythmia called junctional ectopic tachycardia, or JET. This is the most common single postoperative arrhythmia that we see. It occurs anywhere between 6 to 12% overall after congenital heart disease surgery. But if you look at surgical procedures that require manipulation near the AV node, it's up to 30%. And so this is just a little example of JET. It's a narrow complex tachycardia with VA dissociation. The mechanism is thought to be increased automaticity in the AV node, probably due to some transient injury or inflammation in that area due to the surgery. And so Christy Borgman was one of our former fellows. She led this analysis when our cohort was still relatively small. We only had about 300 total patients when we first started looking here. And so she selected actually 5 specific surgical procedures. It doesn't really matter right now what they are, but she selected them because they had a relatively high proportion of JET. And so when she compared the individuals with JET to those without JET, she found that those with JET were younger, had longer cross-clamp and bypass times. None of that was really a surprise. But she also looked at a common polymorphism in the angiotensin-converting enzyme gene, or the ACE gene. And she's found that those with JET were skewed towards being homozygous for the deletion allele. And in the multivariate analysis, the genotype actually had a much higher odds ratio than any of these other well-established clinical risk factors. And so there's a reason for that. So this is a pathway just sort of reminding us the role of the ACE enzyme here. So you remember renin cleaves angiotensinogen to angiotensin 1. The angiotensin converting enzyme converts angiotensin 1 to angiotensin 2. And then angiotensin 2, either directly through the AT1 receptor or indirectly through aldosterone, has a number of effects on cardiac ion channels as well as calcium handling proteins. And so relatively high levels of angiotensin 2 and aldosterone are relatively pro-arrhythmic. And so patients who are homozygous for the D allele have greater ACE activity, higher levels. And so, again, not a big surprise that they had a higher incidence of JET. Now, if you look at this pathway, a couple things come to mind. One is that there's nothing on this slide that makes you think about JET specifically. This is just a general pro-arrhythmic state. And then the other thing is there's a very convenient druggable target here, right? We have ACE inhibitors that we use. And so once we had a larger cohort, this was about 800 patients total. Andy Smith, who is one of our former colleagues here, he led this analysis. And so now he's looking at really any tachyarrhythmia, not just JET, but really any abnormal fast heart rhythm in the postoperative period. And he's looking at almost all of our surgeries, basically any surgery that requires cardiopulmonary bypass, which is really, almost all of them. And so this is a more heterogeneous population. And so here, the ACE ID deletion was significantly associated in the multivariate analysis. The odds ratio was not quite as high. He also saw that preoperative ACE inhibitor use was associated with a reduction in postoperative tachyarrhythmias. And so if you look at the actual risk of tachyarrhythmia by genotype, you'll see it's statistically significant, but I would argue not really clinically actionable. If this genotype was in the EHR and I knew a patient was having surgery, I'm probably not going to treat somebody different because they have a 30-some% risk of tachyarrhythmia compared to a 40-some% risk. But if we look at preoperative ACE inhibitor use, we see this really interesting drug-gene interaction. So ACE inhibitors were associated with a nearly 4-fold reduction in the risk of postoperative tachyarrhythmias in this genetically defined group, that is those who are homozygous for the insertion allele. You see really no effect at all in the DD homozygotes and this non-significant trend in the heterozygous patients. And so, this I'd say is potentially clinically actionable. If I've got a patient who's got congestive heart failure and I need to treat them with a drug, I'm probably more likely to pick an ACE inhibitor if I know they're in this group and they're going to need surgery, because I also would be reducing their risk of postoperative tachyarrhythmias very significantly. And I might be less inclined to pick an ACE inhibitor for this group. Now, obviously, there's more that goes into that decision than just this piece of data. But like I said, that is potentially clinically actionable. Now I'm going to shift gears to talk about another postoperative arrhythmia. This is postoperative heart block. So these arrows are showing you where all the P waves are. That's atrial activity. And you can see the QRSs or ventricular activity is going along with no association at all. So there's a complete lack of conduction between the the top and bottom chambers. And so postoperative heart block is interesting. This used to occur in more than 10% of congenital heart disease surgeries, but it's dropped to less than 3%. But that percentage has been very stable over the last really 10 to 15 years. So despite continued advancements in surgical techniques, that number has remained the same. The other thing to know about postoperative heart block is most patients actually recover one-to-one AV conduction. So this is classic data out of Boston Children's Hospital showing that 54 patients who leave the operating room in complete heart block, you can see a slight majority actually recover one-to-one AV conduction, and they do so for the most part by post-op day 9. And so while patients have heart block, we're basically supporting them with temporary pacing wires. And then every day we're checking to see if they have return of conduction. And if they don't have return of conduction, then they get a permanent pacemaker. And so if you look at current guidelines for permanent pacemakers in postoperative heart block, it's recommended if that heart block lasts for more than 7 days, and that's obviously based on data like this, or if AV block is not expected to resolve. And I put that in quotations because we really have no data on whether or not we expect AV block to resolve or not. And so we thought maybe we could inform that question. So when we had about 1,200 patients, we looked at those who had complete AV block leaving the operating room and those with normal conduction. And again, no big surprise, those with heart block were younger and smaller and had longer bypass and cross clamp time. More often included VSD closure as well as receiving digoxin preoperatively. They were also a bit sicker. You know, they had more dopamine and noradone use, and higher lactates, and more use of ECMO. But look at the length of stay in the ICU and in the hospital. Median of 6 days longer in the ICU and 8 days longer in hospital. And that just mirrors that 7-day waiting period, right? So a lot of these patients would probably be ready to leave the ICU, but we're supporting them with temporary pacing, waiting for 7 days before we implant that pacemaker. If we could predict who was not going to recover, we could probably implant the pacemaker much sooner and get these patients out of the hospital. We also looked at a common polymorphism in a gene called GJA5, and we saw the sort of expected population distribution in those with normal conduction, but a significant skew towards the TT homozygotes in those with complete AV block. And you might wonder why we looked at that particular polymorphism. Well, GJA5 encodes connexin 40, and it's known that a rare mutation in connexin 40 is associated with a form of familial heart block. So these are patients without congenital heart disease. You know, they have structurally normal hearts. They just get early onset AV block due to a rare mutation with a very strong effect. And so we hypothesized that perhaps a polymorphism that's common with a weak effect, you know, one would never be strong enough to cause AV block by itself, but perhaps when combined with the environmental insult of surgery near the AV node could result in heart block. And that's what we appear to see there with the TT homozygous. And so Laura Murray was one of our former pediatric residents here. She's now a pediatric cardiologist in South Carolina. She led this analysis. And in the multivariate analysis, the TT homozygous genotype was associated with postoperative heart block with an odds ratio of about 2.1. And again, if you look at the ROC curve, you can see it's not a bad model. But again, I would argue this by itself is not really clinically actionable. If the risk of heart block is somewhere around 2 to 3%, then with this genotype, it's around 4 to 6%. Again, we're not really going to treat those patients any differently. But I'm actually not quite as interested in predicting heart block after surgery. I'm more interested in predicting recovery of AV conduction because that's the clinical conundrum. So we went ahead and we compared the more than half of patients who recovered AV conduction with those who did not. And interestingly, we found junctional acceleration, that is JET or its slower cousin AJR, in more than half of the patients who recovered conduction. Now, this is not something we expected to find. In fact, we were the first ones to notice that association. We reported this at the Heart Rhythm Society conference a few years back, and since then, that actually has been replicated in 2 other independent cohorts. This is a figure from one of those cohorts. This is a German group that had a similar size cohort, 32 patients with AV block. In those that recovered, they called transient AV block. They actually saw JET in every one of those patients. And in those who did not recover or who remained in complete AV block, none of them had jets. So in this cohort, it was a perfect discriminator. It wasn't quite as good in ours. And in that third cohort that also replicated, the numbers were more similar to what we saw. So again, that's a fairly valid finding. We also saw intermittent conduction more often in those who recovered one-to-one AV conduction. So that'd be something in between complete AV block and normal one-to-one conduction. So it sort of makes a lot of sense. When we looked at our GJA5 polymorphism, we actually saw a similar skew in both those who recovered and those who did not. So no significant difference there. So we don't have a genetic predictor, but we do have two very strong clinical predictors. And again, this has changed my practice at least. When I see either one of these predictors, I think it's worth waiting the full 7 days before implanting a pacemaker. If we don't see them by post-op day 2 or 3, I think we can go ahead and implant them at that point and get them out of the hospital sooner. So just to show you that we look at more than just arrhythmias, here's a recent paper. This was led by Sandra Kikino. She's one of our current pediatric cardiology fellows. And she looked at acute kidney injury after congenital heart disease surgery. And so this table is on here. I don't want you to get bogged down that much in the details here, but this is looking at more than 2,000 patients. And you can see slightly less than half have no acute kidney injury after surgery, but a pretty sizable proportion have either stage 1, 2, or 3 AKI. And what she found in the multivariate analysis is this common variant in nitric oxide synthase 3 actually is associated with a protective effect against AKI. And so, again, a genetic predictor by itself isn't really all that useful if you don't have an intervention. But we actually do have a pretty reasonable intervention for AKI. And this is a paper led by Sarah Van Driest, who many of you know. She led this analysis showing that the proportion of post-op surgical patients with AKI is reduced significantly in a dose-dependent fashion with acetaminophen. All right, and that was shown in our cohort of patients that were recruited here, as well as a validation cohort. These are patients that had surgery at Duke. And so again, in the multivariate analysis, less AKI associated with acetaminophen dose. And so the mechanism is actually very intriguing here. So when you have congenital heart surgery, you have to go under cardiopulmonary bypass. That results in hemolysis, and free heme actually gets oxidized, and that's a relative nephrotoxin. Acetaminophen reduces that oxidized form of iron, and so is protective specifically in the setting of hemolysis. And so again, identifying patients who are at risk for AKI is useful because we have a very well tolerated therapeutic agent for this specific situation. This is a paper that was led by Sydney Rooney. She is a former medical student here who is now a pediatric resident at Pittsburgh. And this actually did not use our consented cohort. This uses our institutional biobank or BioView. And she combined that with 2 other institutional cohorts, one at Iowa and one at UCSF. And she looked at premature infants who received indomethacin to treat their patent ductus arteriosus. And she showed that the CYP2C9 STAR2 variant was associated with failure of indomethacin. That is, these patients required surgical ligation with an odds ratio of 3.74. And so for neonates who are STAR2 at CYP2C9, indomethacin fails in more than half of those patients compared to about a 30% failure rate in wild type. And so, you know, it's probably up to a neonatologist to decide if this is actionable or not. Perhaps if you knew indomethacin was more likely to fail, you may spare them the risk associated with indomethacin and just go straight to surgical ligation, or really nowadays probably more likely catheter-based coil occlusion. This paper also uses our BioView de-identified biobank here, and this was led by Sudeep Santhankar, who is a current pediatric cardiology fellow. Hopefully will be joining our faculty relatively soon. He looked at adverse events associated with propofenone, which is an antiarrhythmic drug in the pediatric and young adult population. And he showed that adverse events were more frequently seen in the poor metabolizers for CYP2D6. And you saw very few adverse events in the extensive metabolizers. This also recent paper is here really just to remind me of something that we realized kind of halfway into this process is, you know, we were collecting a a tube of blood preoperatively to extract DNA. And then at some point we realized, we might as well use the plasma that we're drawing and store that so that we can look at things like biomarkers. And so this is a collaboration with Danielle Sen, who is a cardiac surgeon who spent some time here at Vanderbilt. She's now at Hopkins, and she and her team there actually looked at our serum samples and showed that this novel biomarker GDF15, or growth differentiation factor 15, was associated with poor weight gain. So this is weight for age Z-score and height for age Z-score. And so you can see, of course, many of our patients have failure to thrive. And so identifying biomarkers of poor growth is important in this population. And so this was another use of our stored samples. All right, now back to arrhythmias, right? This is a paper not from our institution, but from Texas Children's Hospital. And they show that postoperative atrial tachycardia in infants is associated with increased mortality. And so we thought that this is an important specific arrhythmia in a specific population for us to investigate. And so Amy O'Connor, who is one of our former pediatric cardiology fellows, she's now a cardiac intensivist at Northwestern. She led this analysis when she was a fellow here. She looked at predictors of postoperative atrial tachycardia, specifically in infants, and she identified some clinical risk factors. And she also looked at 2 candidate genetic risk factors, so common polymorphism in PIDX2 and also IL-6. And she selected these because they were previously associated with postoperative atrial fibrillation after adult cardiac surgery. So they seemed like very logical candidates. But neither one of them actually associated with atrial tachycardia in infants. So we only have clinical predictors so far. So having failed this candidate gene approach, which had worked for us several times in the past, we then went ahead and did an unbiased genome-wide association study for postoperative atrial tachycardia in infants. And we did find a couple of possibly intriguing findings. Our 2 top hits there are 2 genes that have not been previously associated with arrhythmias of any kind. We don't want to get too excited about them just yet. First of all, because none of our hits actually reached kind of the traditional genome-wide significance threshold. It's a relatively small cohort for a genome-wide association study, and we have a replication cohort that we're currently analyzing. So we'll see if anything comes of this. But I show this really just to point out the fact that we have genome-wide genotype data, and with that we can potentially do some other interesting analyses. And so this is a figure that I just stole off the web. I'm not even sure what this GWAS is studying here. It doesn't really matter. It just nicely illustrates a concept that I wanted to explain. So this is obviously a very large genome-wide association study because they have lots and lots of signals that meet the traditional threshold for a cutoff here. And when you have a lot of significant signals, you can actually combine all of them, sort of weighted by their effect size, into a polygenic risk score, or a PRS, sometimes called a genetic risk score, or a GRS. And when you do that, you get a lot of potential information about how variation across the genome influences your outcome. But you're ignoring all these other variants that may also contribute to the phenotype. And so rather than just constructing one polygenic risk score, you can actually construct many polygenic risk scores that all use different p-value cutoff that then get more and more SNPs, to the point where you can just look at all of the ones, all the SNPs you test for, to see how well they contribute to your phenotype. And so what Todd Edwards, one of my statistical genetics colleagues, wanted to do was take some large published genome-wide association studies and evaluate whether or not those polygenic risk scores associated with outcomes in our population. And so Todd was involved with this blood pressure polygenic risk score. This was a very large study, over 700,000 participants. And these included the Million Veteran Program, the UK Biobank, the International Consortium for Blood Pressure, as well as BioView, our institutional biobank. And this is really a polygenic risk score that looks at ambulatory blood pressure, in predominantly adults. And again, since it's so large, they detected over 500 genome-wide significant loci. This was published in 2019 in Nature Medicine. And so he wanted to potentially investigate blood pressure in our post-op congenital heart disease population. And so I sort of quickly pointed out, well, there's a problem with that. In the postoperative period, we don't really allow the blood pressure to be what the blood pressure wants to be, right? We really tightly control that with vasopressors and inotropes and that sort of thing. And so we thought about, well, maybe we could, come up with some fancy score that looks at blood pressure as well as, the amount of inotropes they're on. And it pretty quickly gets fairly complicated. And so then we said, well, why don't we just look at a clinically important outcome that we think might be affected by, a genetically determined blood pressure. And so one of the simplest things to look at was operative mortality. And in fact, the polygenic risk score for diastolic blood pressure was associated with operative mortality. And it does that in this with this interaction here. So we have the hospital mortality here on the y-axis and the diastolic blood pressure polygenic risk score here on the x-axis. And we've got our cohort broken down into a couple of groups here, and they're split by their vasoactive inotropic score tertile. And so the vasoactive inotropic score essentially takes the total number and doses of vasoactive inotropic agents that these patients are on in the first 48 hours. And then we look at those that, require the least amount of support, that is in the lowest tertile, and those that required the most amount of support, that's in the highest tertile. And so you can see those that didn't require any support, in other words, they come out of the operating room not very sick. You can see the mortality really doesn't change no matter what your diastolic blood pressure polygenic risk score says. But those in the highest tertile, you can see a very high operative mortality if they've got a low diastolic blood pressure polygenic risk score, and that mortality decreases as the diastolic blood pressure PRS increases. And you can see those that have a genetically predicted high blood pressure actually have a very similar mortality to those that didn't really require significant vasoactive inotropic support. And so, there's a couple of ways that we can interpret this. One is, if you're really not that sick coming out of the OR, it really doesn't matter. But if you require a lot of support, you're much more likely to survive if you're more prone to have hypertension as an adult. And we also, may explain why we have such a high prevalence of hypertension in our adult congenital heart disease patients. Perhaps those that survive their operations 20, 30 years ago are going to be skewed towards those with high polygenic risk scores. All right, I'm going to now shift gears again. I showed you a slide before that looks a little bit like this. This is not a number of patients or operations, though. This is actually the percentage of patients every year that we've been enrolling that are exposed to one specific pharmacologic agent in the postoperative period. And that specific agent is dexmedetomidine. So dexmedetomidine is a unique drug in that it's the only analgesic sedative that does not cause respiratory depression. So it's used in a wide variety of settings, including in the postoperative period after congenital heart surgery, because it's very useful when you're trying to get patients off the ventilator. And so we took an interest in this, partly because it's a drug that we almost never used when we began enrolling, and now more than 90% of our patients are on it as soon as they leave the operating room. And we also know that this drug has very profound effects on cardiac electrophysiology. So this is data in children undergoing EP studies, and this is at Stanford. So they sort of, did all the kind of EP parameters that we normally look at before and after dexmedetomidine. And you can see dexmedetomidine has very profound effects on sinus node function and AV node function as well. And sometimes dexmedetomidine is used like adenosine to terminate reentrant arrhythmias. And so we thought, we should look at dexmedetomidine use and whether or not we see a significant change in our arrhythmia profile. And so Jackie Shuplock was another one of our former fellows, who's now a pediatric cardiologist. She led this analysis. And again, we don't really need to focus too much on the main findings. Essentially, the bottom line is patients who receive high dose dexmedetomidine have slightly increased risk of bradyarrhythmias requiring intervention. Otherwise, we didn't see a significant change. What I want to focus on is just the variability in total dexmedetomidine dose in the first 24 hours. So this is just a histogram of dose in about 468 children. And again, some of this on the low end we expect because not everybody's on it for the full 24 hours. but you'll see some children get very high doses of dexmedetomidine. In fact, this is more than our protocol, so, technically allows for in 24 hours. And so I'm not suggesting necessarily that these kids are getting too much dexmedetomidine. I think that the clinical team is giving, what they feel is appropriate. The question is more of a scientific one. Why do some children need high doses of dexmedetomidine? Is it a PK effect, sort of like tacrolimus? Do some children need higher drug doses to achieve the same serum level? Or is it a pharmacodynamic issue? Do some children need higher levels of dexmedetomidine in order to achieve the same level of sedation? So the only way we can answer that question is to actually get dexmedetomidine levels and do PK, right? And so this is a really nice study out of CHOP. This is led by Athena Zuppa. And this is, kind of how we typically plan PK studies, right? So we take, a cohort of children, we come up with fixed dosing regimens, and then we sample blood at various time points throughout. And this is a very, very clean analysis. It's very useful. One of the limitations is, you do have to draw, a certain amount of blood at certain times, and that can be tricky, particularly, in critically ill children. And so we've taken a slightly different approach here. And so again, if you look at a traditional PK study, you have a fairly homogeneous group of patients to minimize the variability. You come up with a fixed dosing regimen, and then you sample at fixed time points. And so what we're doing is what we call pragmatic PK. This is a variation on population PK where our target population is simply our entire clinical population. So all the children who are getting surgery that are exposed to this drug, we want to evaluate them. So, that's small children, that's older children, that's, sick, not sick, lots of intrapatient variability in the population. So in some ways it's a bit messier. And we also don't tell the clinical team what dose they should give. They just give whatever they think is appropriate. And then we don't sample specifically for research. As I said, in the postoperative period, we're doing a lot of clinical lab draws. And whenever you do a clinical lab draw, that tube of blood goes to the lab, and they take however much blood they need to run the test you've ordered. And then there's always a little bit of blood left over. And in our lab, after 3 days, those leftover samples are discarded. And so we simply obtain those samples before they get discarded and take them to the mass spec lab, and then we can draw multiple drug levels. And then with that, we can eventually come up with a model-derived and covariate dependent dosing regimen that we think is appropriate for that patient. And so obviously, when you do this, you get a lot of data that is of various quality. And so each one of these panels is a separate patient, and in red is drug administration, and then the little black dots are samples of drug levels. And so, this particular panel here, this is a nice example because, this patient's on drug for a while, and we have lots and lots of samples kind of in that time period. But you also get patients that look like this. So they're on drug just for a very short time, and they have no samples until well after the drug is administered. And so that sample is below the lower limit of quantification. So you have to sort of take all the samples together and get somebody who knows how to do population PK modeling. And fortunately, we have Lena Choi here, who has led these analyses for us. So this is a paper published by her student, Nathan James, is the first author, looking at population PK analysis of dexmedetomidine in our cohort. And so you can see how clearance is affected by weight and to some degree age. So we sort of have plausible weight ranges for various age children plotted here. And we did look at one particular genotype, UGT2B10, and there is an effect on clearance, although when you look at how that would affect dosing, it turns out that one variant alone really doesn't significantly affect how you would alter your dosing. Here's another paper from Athena Zuppa's group. So this paper was attempting to look at dexmedetomidine PK in children on ECMO. And so that's obviously very challenging. And in fact, it was challenging enough that she could only get samples from 8 total patients. So she didn't actually have enough data to sort of come up with her own model. So what she did is she evaluated her data with all the different published models that are out there. And so here's Nathan James's paper. And really, the only reason I'm showing you this is not to really compare the models, but just to show you that these other 5 papers combined, if you look at the number of patients, there's a total of 200. And again, using our pragmatic model, we're able to get 354 patients. So the power of this is really in the size. You can enroll many more patients and get many more drug levels with this type of approach. And I believe this is my last data slide here. So this is another population PK modeling. This is now looking at fentanyl. Again, like I said, we can look at multiple drug concentrations with this approach. And so here we're showing how CYP3A5 does affect the clearance of fentanyl in this population. Again, with a lot of variability within the groups, however. And so if you simulate various drug concentrations for different dosing regimens for a hypothetical patient here, you can see not a huge difference between normal, intermediate, and poor metabolizers for CYP3A5. So that just this one variant alone, would not necessarily be enough to alter dose. And so for a lot of this, I think looking at multiple combinations of genes and in fact possibly polygenic risk scores would be important for us to make a clinically meaningful difference there. And so with that, I just want to thank the very large team that's been doing this. So I have a large team of co-investigators and mentors as well. And of course, the research nurses are the ones who actually do all the hard work of consenting the patients and collecting the data and collecting the samples and so on. I've had quite a few outstanding fellows and trainees that have been doing the analysis. And then just want to acknowledge our funding sources. So NIH and NICHD specifically, as well as the American Heart Association and the Brett Boyer Foundation. And so with that, I am happy to take questions here. So let me see, I see a couple. How do we deal with informed consent when using opportunistic samples? Yeah, so actually, when we get consent from our patients, first of all, since from the beginning, we've been getting genetic data. And so, we've explicitly got permission to use genetic data from the get-go. And then, when we decided to do opportunistic sampling, we basically added language about using leftover clinical samples, leftover plasma and serum from clinical lab draws. So that's built into the consent process as well.
Prince, just to clarify, that's a standard consent for all patients at Vanderbilt?
No.
Or
So
study?
We have a IRB approved study with a specific consent form. So this is not a standing thing at Vanderbilt. This is something that we approach all of our patients in the preoperative clinic, or if they're inpatients by a research nurse, and we get consent from parents or guardians specifically for this observational study, not a blanket thing for everybody that comes here.
Okay, thanks.
Yeah. And sorry, I want to see. There's a question. Early slide data up to 2011 or so, and so a stark decrease in 50. Okay. Oh yeah. Question about if there's any change in deaths related to COVID. Yeah. So what I was showing was specifically deaths related to congenital heart disease. So none of that would be looking at COVID-related deaths. So I don't have any data that answers that question specifically.
Are there any other questions for Prince? Feel free to raise your hand, and we can also call on you and allow you to speak as well.
Have you evaluated if the presence of severe hyperglycemia in your cohort of heart transplant patients on tacrolimus? That is a good question. So yeah, I'm not a transplant doctor, and so I'm not aware of hyperglycemia. Is that actually? I don't even know. Is that a side effect of tacrolimus? Yes, yeah, go ahead and unmute yourself.
Maria, if you want to unmute.
Yes, we see it interestingly in kidney transplant patients. We do see it, and we still don't know if there is maybe race related age-related, but we see it in patients after kidney transplant. Some of them, they are on tacrolimus, and when we switch to another agent, I mean, I'm a endo, yeah, but I take care of their diabetes, and
Yeah.
once the transplant nephrologist change them to another agent, that it resolves.
Yeah, so I don't know the answer to that. And I should clarify, in our study, we are actually only looking at outcomes that occur within the first hospitalization. And so in the acute transplant period, of course, patients usually get pretty high doses of steroids. So there's a lot of hyperglycemia associated with that. I don't know if long-term as an outpatient, if we see more hyperglycemia from tacrolimus. I'm sure our transplant doctors do. But like I said, for our particular study, we really only follow them until they leave the hospital.
Okay, thank you.
Sure. And let's see. I'm not seeing any other questions right now.
Right. Well, if there aren't any other questions, we can go ahead and close our webinar for today. And thank you again for the talk. It was really informative on a variety of precision therapeutic areas in cardiology. So it was really, really interesting. So
Yes,
thank you
well,
very much.
thank you. Bye now.
Bye.